Hi, my name is Dr. Robert Ang from the Asian Eye Institute in the Philippines, and I'm here to give my presentation on the influence of astigmatism on small aperture and trifocal IOL performance. I am an investigator and an advisory board member of AcuFocus. In this study, we wanted to find out what the effect of astigmatism is on these common and popular presbyopic correcting IOLs. We did a prospective single center study. The age group of the patients was 55 to 75 years old, and we recruited patients who have already had cataract surgery with implantation of one of three IOLs. One is the IC8, which is an EDOF type of IOL. One is the 80 Lisa trifocal IOL. And the third one is the Fine Vision Micro F trifocal IOL. How we did it was we started with the best corrected distance manifest refraction, meaning we wanted to neutralize all residual manifest refractive errors. And then we started putting a 2.5 diopter cylinder lens at three selected axes. One is at 90, one is at 180, and one is at the oblique axis. And we gradually remove zero point 0.5 diopters per step all the way to manifest refraction. And by doing this, it's similar to like a defocus curve where you find out how is the degradation of vision with each step of removal of the cylinder. And then we measure the visual acuity. So we, as I said, we use three types of IOLs, the IC8 IOL, the 80 Lisa trifocal, and the Fine Vision trifocal, as you see in these images. So in terms of results, how did we do? In terms of astigmatism tolerance curve at the 90 degrees, as you can see, the IC8 is represented as blue dots, the Fine Vision trifocal IOL in the dark orange, and the 80 Lisa in the light orange. And as you see, all three lenses show a degradation of logmar visual acuity as you keep adding cylinder. However, you also see that the slope of degradation of the IC8 is much slower than the other two trifocal IOLs. The asterisks symbolize statistical significant differences. Is as you can see, both all three IOLs degrade at 0.5 and at one cylinder 1.5, so on and so forth. But you see also that the IC8 retains 0.01 logmar or 2025 all the way up to 1.5 diopters of induced cylinder. So it means that it has a tolerance up to 1.5 diopter cylinder, whereas in the Fine Vision and Lisa trifocal, at zero point 0.5 and 1 diopter, they already degrade by more than 0.2025 vision. We also tested at the with the rule astigmatism of 180. As you can see, again, the pattern follows that all three IOLs degrade as you add more cylinder, but the IC8 degrades less than the other two. All three degrade at a slope maybe a little bit slower than the against the rule, but still the pattern holds that the IC8 maintains 2025 vision all the way close to 1 to 1.5 diopters. Then we also tried oblique. So at oblique axis, you see that the difference between the trifocals and the IC8 are much more pronounced, meaning the IC8 is more tolerant of astigmatism all the way up to 1.5 diopter cylinder, retaining 2025 vision, whereas the other two lens at 0.5 diopter cylinder at the oblique axis, they already dropped to 2025, and it got much worse from there. Now, the tricky part is before surgery, we have to choose or decide if the patient would need a toric IOL or not. So in my practice, I begin at 0.75 diopter corneal cylinder and above, I would already recommend a toric IOL. Now, if you recommend a toric IOL, you have to make sure that you put the lens on axis, meaning after you compute the IOL axis alignment, you have to put the lens there, and you want to at least make sure that with the lens that you choose does not rotate so much that it negates the cylinder correction. So in this slide, you can see that if there's a 1 degree rotation in a toric IOL, there's minimal change in effect, minimal change in vision and minimal effect. The IC8 retains all its effect, and as you are more off axis, meaning the higher the axis displacement, 5 degrees, you lose 17% of the effectiveness of cylinder correction. At 10 degrees, you would have lost one third. And at 30 degrees rotation, you would have lost all the effect of your toric IOL correction. So as you can see that uh, aligning the lens and making sure it stays where you want it to stay is important in toric IOLs. Whereas in the IC8, because of the small aperture or pinhole optics, it doesn't matter where you put the axis of the IOL. It can be vertical, horizontal, it can rotate, and it doesn't matter much because the small aperture is the one that is negating the corneal astigmatism. So meaning that you don't have to worry about alignment if you decide on using an IC8. So in conclusion, the IC8 provides nearly 2 to 3 diopters of extended depth of focus for presbyopia correction. But in addition to that, it gives us a tolerance of up to 1.5 diopters of corneal astigmatism. The beauty of it is 82% of the cataract population has less than 1.5 diopters of corneal astigmatism. So there's a big market for low toric IOL correction and a residual astigmatism either from uncorrected preoperative corneal astigmatism or as a result of surgically induced astigmatism. We see here in this study that it degrades visual quality and visual acuity. And the symmetric nature of the small aperture IOL mitigates the influence of astigmatism axis. It also eliminates the need for alignment, so we don't have to compute your toric IOL axis before surgery. We don't have to mark the corneal axis pre-op in the slit lamp, and we don't have to mark it intraoperatively. So there's a big convenience factor here if you use the IC8. So the IC8, in conclusion, may provide surgeons with a good solution for addressing low levels of preoperative astigmatism without concern or without worrying about axis alignment after surgery. You also don't have to worry about reduced performance or degradation of vision if your IOL rotates after surgery. Thank you very much.